So hello students, our today's topic is the it is about the pulp protection. So what is the main goal of the operative dentistry? The main goal of operative dentistry is to preserve the health of the dental pulp. So pulp, when exposed, it is extremely sensitive to the contact and the temperature. So the pulp, it can get irritated by various restorative materials and the dental procedures. So in order to protect the pulp from the various irritants, various pulp protective agents we use. What are the pulpal irritants? What is the main cause of the pulpal irritation? The most common cause for the pulpal irritation are the bacteria and their products that will enter the pulp by the process of the caries. Any accidental exposure, fracture, or any infection from the gingival sulcus. So, in order to in the response process, what the pulp will follow a defensive reaction process that takes place in the carious tooth, that is to protect the pulp. Number one we see is the formation of the reparative dentine. So this reparative dentine formation, it is inversely related to the rate of the carious attack. So more the caries attack, lesser will be the reparative dentine formation. Other protective mechanism or the defense reaction that takes place is the dentinal sclerosis. There is reduction in the permeability of the dentine by narrowing of the dentinal tubules. In dentine sclerosis, what you will see is the dentinal tubules, they will be partially or fully filled with mineral deposit. So that will reduce the permeability of the dentine. So this dentinal sclerosis would act as a barrier to protect the bacteria and their products to enter inside. What is the effect of the tooth preparation on the pulp? So suppose you are having a handpiece and the pressure of the instrument, what it will cause? It will cause the aspiration of the odontoblast into the dentinal tubules. So there will be complete degeneration and the disintegration of the odontoblast. Other factor is the heat factor. If the pulp temperature is elevated, there will be a destructive reaction. So heat is a function of RPM. More the RPM, greater will be the heat production. More is the contact between the tooth and the revolving tooth, greater will be the heat generation. Pressure, the pressure is directly proportional to the heat generation. Desiccation, the desiccation can cause aspiration of odontoblast into the tubules. So that can lead to complete degeneration of the odontoblast. Vibration, they are measured by their amplitude or their frequency. So vibration, so higher will be the amplitude of the vibration, more destructive is the pulp response. Speed of the rotation, ultra high speed should be used for removal of enamel and superficial dentine. A speed of 3000 to the 30,000 rpm without coolant will definitely cause the pulp damage. Use of worn out instruments, dull instruments, they can cause vibration and reduce the cutting efficiency. So in order to do more cutting, what the dentist do is he will apply more excessive pressure. So if the more pressure is applied, if the pressure is more, then the temperature will increase. That will cause the thermal injury to the pulp. Other important factor is the remaining dentine thickness. So what is remaining dentine thickness? Suppose this is the floor of the tooth preparation and this one is the pulp chamber. So the dentine that is present between the floor of the tooth preparation and the pulp chamber, it is defined as remaining dentine thickness. So remember that generally 2 mm of the dentine thickness between the floor of the tooth preparation and the pulp, it will provide an adequate insulating barrier against the irritants. So as the dentine thickness will decrease, the pulp response would increase. So remember the pulp will need protection from the various irritants. The pulp needs chemical protection, the pulp needs thermal protection, the pulp needs mechanical protections. So how do you protect the pulp? In the case of the shallow and moderate carious lesion, while in the deep carious lesion. In the moderate carious lesion, what you will see is the caries will penetrate the enamel and will involve the half of the dentine. So in these cases, to protect the pulp, the dentist apply liner to cover the axial and the pulpal wall, and over the liner a base is placed, and after the base material sets or hardens, the dentist will place permanent restoration over it. Whereas in the case of the deep carious lesion, where the caries will reach very near or up to the pulp, so treatment of deep carious lesion will require precautions, because there will be post-operative pulpal response. So what are the treatment modalities you can do, or the pulpal protection you can give? What you can do is the indirect pulp capping. So the indirect pulp capping, it is a procedure that is performed in tooth with the deep carious lesion. So what you will do is you will remove all the infected carious dentine, so leaving behind the softened carious dentine adjacent to pulp. The caries near the pulp, it is left in the place to avoid pulpal exposure, and the preparation, it is covered with a biocompatible material. So it is indicated in the deep carious lesion, where the lesion is near the pulp tissue and not involving it. There is no tenderness to percussion. The tooth is non-tender to percussion. There is no radiographic evidence of any pulpal pathology, no root resorption. So it is contraindicated in case where there is pulp exposure, in case where there is radiographic evidence of the pulp pathology. If the tooth is sensitive to percussion, there is mobility in the tooth or root resorption. Other is the direct pulp capping. Suppose there is a pulp exposure. So direct pulp capping involves the placement of the biocompatible material over the site of pulp exposure to maintain the vitality and promote the healing. So suppose a small mechanical exposure of pulp, it occurs following a trauma case. So what you will do is apply a protective base that should be placed in contact with the exposed pulp tissue that will maintain the vitality of the remaining pulp tissue. So where direct pulp capping is indicated? When there is a small mechanical exposure of the pulp during tooth preparation or any traumatic injury, and there should be no or minimal bleeding at the exposure site. The cases in which direct pulp capping is contraindicated when there is a wide pulp exposure, when there is evidence of pathology, presence of bleeding at the exposure site, or patient experience a history of pain. So just apply a dical of the calcium hydroxide over the exposed area and give anterim restoration like zinc oxide eugenol for 6 to 8 weeks. So, what are the factors that will affect the success of the direct pulp capping? Number one is the age of the patient. Why young patient has a better prognosis? Because they have a very good vascular supply. So, due to the vascularity of pulp, the young patient will have greater potential for success. The mechanically done exposed pulpal exposure has a better prognosis than that is exposed by the caries, because in that case there will be a less pulpal inflammation. While in the case of the large exposure, it is difficult to control the bleeding. Whereas the small pinpoint exposure, they are easy to manage and they will have a greater potential for the success. Now the materials that we use for the pulp protection, their main function is to insulate the pulp, protect the pulp in case of deep carious lesion, act as a barrier to prevent the micro leakage and prevent the bacteria and the toxin from affecting the pulp. So how do we classify these pulp protective agents? We can classify them as cavity sealers, varnish, liners or bases. Number one is the varnish. What is varnish? Varnish, it is an organic copal or resin gum that is suspended in the solution of ether or chloroform. So what is varnish? It is an organic copal or resin gum that is suspended in solution of ether or chloroform. So when you apply varnish over the tooth, what you will see that the organic solvent will evaporate, leaving behind the protective film. So how many coats of varnish do you generally apply? 2 coats of varnish they are applied using a small cotton pellet. So that will prevent micro leakage. In case of amalgam restoration, the varnish would improve the sealing ability of the amalgam. There will be reduced post-operative sensitivity. And the discoloration can be prevented by checking the migration of ions into the dentine. So by applying the varnish, what you will see there that will seal the dentinal tubules. It will act as a barrier and protect the tooth from the chemical irritants from the cement, and it will reduce the micro leakage around the restoration. So varnish, it is applied on the walls of the prepared cavity to decrease the micro leakage and prevent the tooth discoloration of the tooth. Why varnish? It is contraindicated under the glass ionomer cement. Varnish, it is contraindicated under the glass ionomer cement. It will interfere with the bonding of the tooth to the cement. So that is why the varnish we contraindicate under the glass ionomer cement. Also, with the restorative resins, varnish is not used, as the varnish liners dissolves in the monomer of the resins, and that also it interferes with the polymerization of resins. So what is base, liner and the varnish? Remember, the cavity varnish, base, liner or sealer, they are the integral part of the operative dentistry, which has a main goal of preserving the health of the dental pulp. So in the operative dentistry, the main objective is to restore the tooth affected by either caries, trauma or etc. with the restorative material. So what is the difference between the liner and the base? Remember, the liner, they don't have sufficient thickness, hardness or strength to be used alone in the deep cavity, or nor should be they used to achieve thermal protection or as build-up material in cavity preparation. Whereas in comparison, base, they not only provide a barrier to the chemical irritation, but they can also provide the thermal insulation. So which is the best liner for the deep cavities? Remember, the calcium hydroxide liner, they are most frequently used for the deep restoration due to their high pH, which stimulate the formation of the reparative dentine. So liner, they are typically the fluid material and they can adapt to all the aspect of the tooth preparation. So liner usually don't have sufficient thickness, hardness and strength. So the indication of the liners, they are used to protect the pulp from the chemical irritation by sealing ability to stimulate the formation of the reparative dentine. Now what are the materials that we use as a liner? The dentist can use zinc oxide eugenol liners. As the eugenol, it has effect to calm down the pain from the mild to moderate inflammation of the pulp. In the low concentration, it acts as an obtundant, whereas in the high concentration, it will act as a chemical irritant. Remember, it should be not used as a base. It should not be used under the composite restoration, as it inhibits the polymerization of bonding agent and composite. Other is the calcium hydroxide. It stimulates the reparative dentine form. It stimulates the reparative dentine formation and forms a mechanical barrier. So, because of its high pH, it neutralizes the acidity of the cements. It is biocompatible in nature. So, bases they are used as pulp protective material since they provide thermal insulation. So they will provide recovery of the injured pulp from the thermal, mechanical or chemical trauma. We can classify them into protective base, sedative base or insulating base. So the protective base will protect the pulp, sedative base will help in soothing the pulp, the insulating base will protect the teeth from the thermal shock. The materials used are zinc oxide, eugenol, zinc phosphate cement, polycarboxy, polycarboxylate cement, and the glass ionomer cement. So this table is important, showing the method of pulp protection from the different restorative material. So if the remaining dentine thickness is greater than the 2 mm, then we under the amalgam restoration we use varnishes, while in case of moderately deep cavities we use bases like zinc phosphate, zinc polycarboxylate. And in case of the deep cavities where the remaining dentine thickness is merely less than 0.5 mm, we use calcium hydroxide as sub base that is covered with a base. In case of the deep cavities using restoration like glass ionomer cement, we use calcium hydroxide as a liner. In case of deep cavities with the composite resins, we use calcium hydroxide as a liner followed by a GIC base, and over it a composite restoration can be given. So remember, the bases they have sufficient strength so as to withstand the forces of mastication and condensation of the permanent restoration. The commonly used bases are the zinc oxide eugenol, zinc phosphate cement, GIC, and calcium hydroxide cement.